So next speaker, he is Dr. Ammar Kheir, consultant gastroenterologist and therapeutic colonoscopist working in Cleveland Clinic, Abu Dhabi. His topic is how to maximize your adenoma detection rate. Dr. Kheir was a consultant gastroenterologist and therapeutic colonoscopist at Queen Elizabeth II Jubilee Hospital. He was also a senior lecturer in the Faculty of Medicine at the University of Queensland, Brisbane, Australia. Dr. Kheir graduated medical education from Sudan, trained in UK, Australia, and Japan. Dr. Kheir has a particular interest and expertise in image-enhanced endoscopy, high-quality colonoscopy, bowel cancer screening in adults, inflammatory bowel disease, management of colonic polyposis, advanced endoscopic resection techniques, Barrett's esophagus, and screening for early gastric cancer. Thank you, sir. Please start.
Thank you. Good morning, everyone, and thank you, Dr. Yogesh, and the organizers for the invitation. Change the title a bit because it's not only adenomas that we are looking for here, but it's actually all neoplasias, including the serrated lesions. So I changed the topic to how to maximize your neoplasia detection rate. So I have no disclosures. Okay, so sorry about that, guys. I want to share what I do for my own colonoscopy. So my published adenoma detection rate is 59% with a serrated lesion detection rate of 28%. That's from 2017, 5 years ago. I routinely use distal attachment for all my colonoscopies. That's from mucosal exposure. I ask my nurse who's with me to also look at the screen. So we have 4 eyes on the screen to help me if I've missed a polyp. I do a 2 minimum examination in the right colon with proximal colon retroflexion up to the mid-transverse colon and perform optical diagnosis for all colonic polyps. Sorry, it's not... I need the screen here open. I can't see it. Yeah. Okay. So the adenoma detection rate is the priority quality indicator for all colonoscopies. It's the number one, together with screening, assigning screening and surveillance intervals, post-colonoscopy, and seeker intubation rate. So these 3 main endorsed criteria by the societies are endoscopist related. And then we also have the bowel preparation adequacy, as Dr. Arun has spoken. So the ACG and ASG target for that is 85%, but here in the UAE is 90%. So the ADR initially was a target for 20% for mixed gender, 25% for men, and 15% for women. But now the ADR is actually gone up to a overall 25%, with 30% for men and 20% for women. The DOH target, as we said, for bowel preparation is 90%, and we're still at the old ADR target of 20%. And I'll explain why we should probably look into increasing the ADR rate. So why ADR is important? So we know the ADR is validated predictor for developing colorectal cancer and interval colorectal cancer. We know that for every 1% increase in ADR, it translates into a 3% reduction in the risk for interval colon cancer and a reduction of 5% for dying from that interval colon cancer. So, for example, here, if we increase the ADR by 3%, this will translate into a 9% reduction of reduction in interval colorectal cancer and a 15% reduction in that patient dying from interval colon cancer. So it's a big deal. So how do we measure ADR? So ADR is the number of patients age 50 and above who are undergoing their first screening colonoscopy. So it's not a diagnostic and it's not a surveillance colonoscopy, who have 1 or more adenoma, and you divide that by the total number of patients undergoing a screening colonoscopy. So that's an example there. If you have 100 patients undergoing a screening colonoscopy, age 50 and above, if you have 1 or more adenomas in 39 of them, your ADR is 39%. So we know that the molecular pathways for colorectal cancer that up to 80% of them arise from the conventional pathway, where the culprit polyp here or lesion is the conventional adenoma. But then we also have up to 30% of colorectal cancer that arise from the serrated pathway. So that's why it's important that we also monitor our sessile serrated lesion detection rate. So the sessile serrated lesions are not part of your ADR, so you should not be including them. It's purely the conventional adenomas. And there are a number of issues or reasons why it's not included, but the main issue is that there is an inter and intra-observer variability among pathologists. So we don't want to get into the issue of reporting sessile serrated lesion detection rate and end up reporting actually the pathologist performance in detecting them. But one way of, and this is what I do here in Cleveland, and we've done that before, is that we rely a lot on the optical diagnosis. So you can see here in the images, all these lesions are high confidence sessile serrated lesion, and if we are really committed and we know that it's a sessile serrated lesion, we include that in the report. And if the pathologist reported as a hyperplastic polyp, then we help them to really look at it again, calibrate them, and with time your pathologist will be very experienced in really diagnosing these lesions. But the good news is that most of the studies have shown that even if you don't measure the sessile serrated lesion detection rate, as long as you control your ADR, that most of the studies are reassuring that your sessile serrated lesion detection rate correlates very well with your ADR. So what is the target for serrated lesion detection rate or sessile serrated lesion detection rate? So these are the published papers. So most authorities are proposing that we should aim for a target probably of an 8%. As the minimum expected sessile serrated lesion detection rate. So what is a master level ADR, and what is being achieved around the world? So most of the expert colonoscopists are reaching routinely a ADR of 48% and up to 50% regularly. And we do know that, if you reach a 35% ADR, that gives probably a very strong protection against developing colorectal cancer and interval colorectal cancer. So right now, I strongly recommend that the minimum standard should be for a mixed population where you're including both men and women, that the ADR should be 25%. And people have also looked at whether there's a population difference, let's say if you're in the US or Europe or the Middle East or Australia, and do you need to adjust for your ADR target? But all the studies are showing that it's actually very comparable and there is no need for that, and we don't want to complicate the ADR any further. So a quick word about withdrawal time. So it should be recorded in every examination, because we know that both the withdrawal time and ADR both predict the development of colorectal cancer and interval colorectal cancer, especially in retrospective studies. Unfortunately, prospective studies have not shown that the withdrawal time monitoring is working, because even though you put a stopwatch or a timer for the endoscopist, that does not necessarily mean that the technique is implemented and it's up to the expected standard. So most of the studies are for the withdrawal time are the retrospective studies. So what is the best withdrawal technique to reach an aspirational ADR? So you should really be looking behind every fold in all quadrants of the colon, having an obsessive mentality of cleaning the preparation. If you do that, you would easily reach more than 6 minutes. So even though the target is 6 minutes, but realistically, if you do all of that, you will end up with about 9 minutes withdrawal time. Now, another important point, that the withdrawal time is your inspection time. It does not include any intervention you're doing or any cleaning or suctioning. So that time that we start, let's say if you reach a CECAM and you start the stopwatch, you should not expect that your finishing time is 6 minutes. That means that you've either had a 100% excellent prep where you did no intervention and you only spend the 6 minutes, which is almost impossible in colonoscopy. So usually you would end up almost spending 10 minutes total to up to 15 minutes withdrawal time. So these are some of my personal opinions about how can we really, improve the quality and the cost effectiveness of colonoscopy, because we are really heavily invested in colonoscopy to prevent and protect against colon cancer. So I think we need to really move into more serious auditing of the ADR and giving feedback to all of us. We need enhancement and supportive programs in the country so we can really maximize the ADR performance. And at least in the US, there has been reported incidents about 10 years ago where ADR has been gamed, where it's a per patient measure or per patient metric. So you can do a colonoscopy, find a polyp or an adenoma, you remove it, it's already included, and then for the rest of the examination you may not be as focused, and then you're not really clearing the colon from all adenomas. And the other potential that you can have an indication gaming, so let's say if a patient has got some constipation and they come in for their first colonoscopy, depending on what you find, you can actually then put the indication. If you found a polyp, an adenoma, then you put it as a screening colonoscopy, or if you found nothing, then you put it as a diagnostic colonoscopy. So that's been actually also seen mainly in the US. So what are master detectors doing? So the most high detectors are only doing routine things. So having a good knowledge of what they are looking for, having a split dose, high quality preparation, using their usual scopes, and that to some extent will be very high enough for you to reach an inspirational adenoma detection rate. So as you saw with Dr. Arun's lecture, but here on the left side, you can see the difference between a split dose preparation on the right side and a all-day preparation from the night before. So that's the mucus that you want to try and prevent when you're doing a colonoscopy, so you can detect all lesions. It's also important that we understand that the majority of polyps are subtle. So the majority of them are actually Paris 2A, so 70 and up to 80% of them are flat, very subtle polyps. And if you put that in mind, then you'll be more obsessive in your examination to ensure that you have detected all polyps and removed them. So what about interventions that can improve ADR? So there's two techniques we do to find adenomas: the looking, so exposing the mucosa, and then being able to recognize when the lesion is in front of you that you're actually seeing it. So we need a mucosal inspection skill and a lesion recognition skill. And we don't know which one is more important. In my opinion, both, but I think that we need to heavily invest in exposing the mucosa and having a good mucosal inspection technique. There's a good article for those who are interested that was published this year by the ASGE that looks into all interventions to improve the ADR. So just running through some of them. So technique-wise, if you increase the withdrawal time up to 9%, up to 9 minutes, that increases your adenoma detection rate by 9% compared to your 6-minute standard withdrawal time. So, and retroflexion in the right colon increases by 17%, a second look exam by 10%, and position change is mainly for improving the colonic distension, so you can easily see all adenomas. I'll skip on the video here. So remember that looking twice can save a life. What about technologies? So distal attachment can increase your adenoma detection rate by up to 11%. You can use chromo, whether it's a dye chromo or electronic chromo. And then we also have computer-aided detection, which I'll show you some examples. So these are the examples of distal attachment. So on the left, you see the transparent cap, and the image below that is what you see. So here you can see an adenoma in range where I'm using a cap at the distal end of the scope. In the middle there, that's the endocuff, the first generation. Now we have the endocuff vision. That's a single row with longer arms. So, and in the photo below that, you can see the arms being engaged and activating, flattening the folds of the sigmoid, almost like a, as if you're going through a descending colon. So this is using the endocuff vision, which is also available here. On the right is the endo rings, which are not available here in the UAE. So chromo helps by highlighting the borders of the lesion and the irregularities and subtleties, so you can really easily see all polyps and be able to remove them effectively. So this is an example here of what I call a ghost polyp. You can look at the image there. You may not see that there's anything there, but once you put chromo, you can see there on the left side that the polyp is, clearly visible, which you cannot see on the first image with white light. These are different technologies. So on the left, it's a white light. In the middle, it's a BLI, blue light imaging. And on the right side, you have the LCI, linked color imaging. And all of these are working towards highlighting or increasing the contrast of the image so you can see polyps easily. Some of the other interventions, as Dr. Arun have said, the split dose preparation. So if you look at the split dose bowel preparation, it increases your ADR by up to 26%. And this is really, really, really important. So just by doing that, you really gone almost more than 25% by improving your ADR chance. The other thing is asking the nurse who's with you to just look with you at the screen, and that can go up to 20%. So if you just do these two things, I think you really have a very safe ADR. Education and feedback, so feeding back, having regular report cards also can increase your ADR. Lastly, about artificial intelligence, I think we have a lot of technologies that we've been using for a while, but artificial intelligence has revolutionized the way we manage a lot of aspects of medicine, especially in colonoscopy. I think we should be proud that we are leading the medical field into utilizing the AI. So what is AI? So it's basically computer programs that helps you to perform the intelligent functions that a human needs. So we have a lot of categories that I'm not going to go through, but we use computer vision. So computer vision is where it's similar to your iPhone or any phone where you have a facial recognition. So the computer is or your colonoscopy software is able to detect polyps in the screen where you may not see it or take time to see it, and it will highlight to you that there's a polyp that you can see and hopefully effectively remove. These are some of the aspects we can use AI for in colonoscopy. I'll just focus on detection. And before that, I'll just show you quickly a meta-analysis that shows that, so this is really a striking, so this is a meta-analysis of 5 randomized controlled trials. And it's very hard to see in a meta-analysis that all studies have shown that AI works or an intervention works. And here, if you look at it, even through, by the expertise of the endoscopist or by the polyp size, whether it's a diminutive, small, large, all of them, show that AI does increase your adenoma detection. Even with the location, if it's a proximal or distal, again, AI, is much more superior to just a standard colonoscopy. Can you play this for me? Yeah. So here AI is in action. So on the left-hand side is on retroflexion. And once you come into an area where the polyp can be seen, you'll see a frame flashing in the screen. And here you can see that the polyp is in view. Can you play the next one? The one on the right? Yeah. Thank you. So even when you have a suboptimal bowel preparation, you can see that, you can see that the AI is detecting polyps and helping you to not to miss any. Let's go to the next one, please. Oh, I can change from the, okay, thank you. Okay, let's see if it plays, yeah. So, if you just look on the right side of the screen, so AI, you can just play that, yeah, the one on the right, yeah, thank you. So AI now is activated, and you can see even those 2 videos are identical, but if you look at the left side of the screen there, so you can see that the polyp, has been probably detected much faster than a human eye can actually detect. Can you play that one again? The one on the right, please, yeah. Yeah, that's fine, yeah. So just look at the right side of the screen, and just see if you can beat the AI to see the polyp. So you can see there, so AI has actually detected the polyp much faster than our human eye. Fine, last slide there. I'll skip on the detection mode there, but all I want to say here, that's not working. Can you skip the remote? Yeah, get the next one, please. Keep skipping, yeah. Yeah, so this is just a characterization way that you can also tell which which type of polyp it is using the AI. You can go to the next one. Yeah, almost finished there. Yeah. Skip on that. So I'll just say a quick word. Just next one, please. Next. Yeah. So this is a Nordic study that has created a lot of controversy. Just next slide, please. Yeah. Next. Yeah. Yeah. Okay. That has questioned whether actually colonoscopy does work or not. So just keep going, please. Yeah. Next. Next. And I'll just take you straight. Go next, please. Just to the summary table there. Next. Yeah. Next. Next page. Yeah. Next page. Yeah. Stop here. Yeah. One more. One more. So one thing to say that the Nordic study has reported an intention to treat analysis, and it's not a per protocol analysis. So colonoscopy still reduces, even though there's a lot of issues with the study, which we're not going to go through now, but colonoscopy still can reduce up to 50% of mortality, and not the 10% that was reported in the abstract. Next. Let's go to the final slide now. Yeah. Next one. That's it. Yeah, thank you. So just to summarize, ADR is an essential measure for preventing colorectal cancer. Interval colorectal cancer is highly operator dependent. Colonoscopy quality is an ongoing issue, even though now it's almost 2 decades since we invested heavily on colonoscopy, but we're still not there yet. And we are, as colonoscopists, have a responsibility to really make it succeed. And to reach a master level ADR, as long as you know what polyps or disease spectrum you're looking for, doing your split dose bowel preparation, doing a meticulous technique, having a second look exam, having an assistant with you to look at the screen while you're doing the procedure, that can easily get you to a master level ADR. And I strongly recommend that everyone should try and attempt to do a right colonic retroflexion exam. It's safe, easy, very effective, and AI in colonoscopy is here. Thank you. Next one. And thank you again for the invitation to present.
As we are running short of time, I request the next speaker to proceed, and there will be definitely many doubts. Please, I request all the floor and audience doctors to discuss with the speaker during his break time. Thank you.
One thing about the last study you mentioned, Ammar, the Nordic, they don't use sedation in colonoscopy. Interesting.
Yeah.
The Nordic study, they mentioned they do not use sedation in colonoscopy. Can you comment?
Yes. I think the majority of them have not used sedation, which I think we believe that if you use a...
Big issue.
Yeah, it's a big issue. And not only that, but actually in the whole study there was not a mention of the serrated pathway, which we know accounts for up to 30% of colon cancer. And I know that it was probably before it was fully described, like the pathway was fully described, but still there was the group from Holland that have, are really one of the world authority on serrated lesions, and they have not mentioned anything in the paper. The other thing is that the ADR in that study was probably suboptimal. Like 2 countries out of the 3 that they reported was below 25%, and this is not something that we would really be comfortable with in 2022. And there's a lot of other issues, but I think we need. It's an excellent study. We should really congratulate them because I think it's a long-awaited study. We still know this is the 10-year reporting. We expect an increase in the efficacy of colonoscopy once we get to 15. And one of the 2 issues I guess I just highlight here that in their study they did a one-off colonoscopy, although that's at least what they reported, and then they waited for 10 years. And about 15% of them, they had advanced adenomas. So we would not do a colonoscopy and not to follow up for 10 years. I think you should, this strongly, I think, discourages the 10-year, or first of all, the one-off colonoscopy and then wait 10 years, which is actually against our DOH guidelines. I know that the Americans say 10 years, but our population here is different. We start younger age, we have a higher incidence of colon cancer, and the DOH only allows for 5 years, but we should not really be invested in 10 years when...
We'll do one day discussion on this. Thank you very much.